With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi everyone, and welcome to the September 2019 edition of PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors Lily Mundy from Duke University and Kyle Sanniec from UT Southwestern. Today we have the honor of being joined by Dr. Scott Hollenbeck, plastic surgeon and associate professor of surgery at Duke University. Thank you so much, Dr. Hollenbeck, for joining us for this PRS Journal Club podcast.
Sure, my pleasure. Happy to be here.
The articles that we will discuss can be read for free on PRSjournal.com, including an archive of all past Journal Club articles. The next article we will be discussing is Microsurgical Breast Reconstruction in the Obese, a better option than tissue expander implant reconstruction, by Dr. Klement and her group at MCW in Milwaukee. In this article, the authors evaluate and compare outcomes in patients who are obese, defined as a BMI of 30 or greater, who are undergoing breast cancer reconstruction after a mastectomy. The two groups that they're comparing are free tissue transfer, or abdominally based microvascular breast reconstruction, compared to prosthetic reconstruction. They evaluated patients over a 3-year period, and they evaluated and looked at outcomes, including clinical outcomes as well as patient-reported outcomes. The purpose of the study is to compare what these outcomes are in these patients, and the authors hypothesized, based on prior studies and their understanding anecdotally, that patients who are obese would have better outcomes, both patient-reported and clinical, with free tissue transfer compared to prosthetic breast reconstruction. In the study, the authors looked at 96 patients who underwent 141 reconstructions. They collected data on demographics, intraoperative and postoperative variables, and they used a BreastQ to record patient-reported outcomes. The results demonstrated that prosthetic breast reconstruction had an increased risk of major breast complications, including mastectomy, flap necrosis, infection, and an overall reconstructive failure, compared to autologous breast reconstruction. When evaluating the results on the BreastQ, or patient-reported outcomes, they report that the patients undergoing autologous reconstruction had improved satisfaction with breasts in that domain, as well as the domains of satisfaction with outcomes, psychosocial well-being, and sexual well-being. The authors subsequently conclude that in the obese population, defined as a BMI greater than 30, that reconstruction with abdominally based microvascular tissue has decreased complications and higher patient-reported outcomes, including satisfaction, when compared to prosthetic breast reconstruction. So the reason I chose this paper is because I think obesity is obviously a major public health epidemic, and it's a problem that's not going away. For example, the rate in the U.S. has doubled in the last 20 years. In 1998, it was 18%, and in 2018, it's now 36%, or 1/3 of the general population. So I think that's something that all of us that are entering practice soon, and everyone who's still practicing, is seeing more and more clinically, and certainly in Missouri, we're seeing a larger population of our patients undergoing breast reconstruction who are obese. So I think that's important to discuss. It's something that several groups have written about. Similarly, the MD Anderson group wrote about it in 2012 with Dr. Garvey, reporting that the reconstructive failure rate was around 16% for patients undergoing prosthetic reconstruction, compared to around 1.5% for patients undergoing microvascular reconstruction. And anecdotally, in our experience as well, our preference is certainly in patients with higher BMIs, up to a limit obviously, but in patients with higher BMIs who are candidates for breast reconstruction, to perform autologous microvascular reconstruction, and typically from the abdomen, as long as there's no contraindications. I do want to comment on a few things in the article before I get Dr. Hollenbeck's thoughts, and I think one of the major limitations of this paper that's important to acknowledge is the differences in the groups at the get-go, and I think that's something that the authors really didn't control for in their statistical analysis. For example, nearly half of the patients in the prosthetic group received radiation, which is a major risk factor for postoperative complications with implant-based reconstruction. Furthermore, even more problematic, nearly all the patients, 42 out of 43 in the prosthetic cohort, had immediate reconstruction, whereas only half of the patients in the autologous cohort had immediate reconstruction. So a lot more patients were undergoing delayed reconstruction, and prior studies have definitely demonstrated that there is a higher risk with immediate reconstruction compared to delayed reconstruction. And that certainly could explain the higher rate of mastectomy skin necrosis in the prosthetic group if there's more of them undergoing immediate reconstruction as opposed to waiting for the skin envelope to be stable. And clearly patients with skin necrosis would then have a higher overall complication rate, including unplanned procedures. So I do think that's important to acknowledge in the study, is that the groups are not exactly the same to start with. And I do think that logistic regression modeling would have been able to control for confounding variables and give them a more accurate measure of this association between the type of reconstruction and the outcome of interest. But with that said, I do think it was a very good paper and a very important paper for everyone who does breast reconstruction. And I want to go ahead and get your thoughts, Dr. Hollenbeck. What do you think about this paper, and what is your preference in patients who are obese as defined by a BMI greater than 30?
This comes up all the time, and this is one of my areas of interest, and even to the research level. And I have this conversation almost every single day, whether it be with a breast surgeon referring a patient, with a patient themselves, or with one of my colleagues, and that is, what do we do about obesity when it comes to breast reconstruction? This paper is helpful in that it highlights the risk of doing implant-based reconstruction in obese patients. As you alluded to in your summary, that's been shown by multiple studies, as well as other studies which show long-term satisfaction is much lower in obese patients with an implant-based reconstruction. So there's a lot of information out there to support this paper, and this further adds to that. You mentioned all the potential pitfalls with the paper and shortcomings with any kind of paper that's a retrospective review, but I think the authors did a nice job of dealing with those as best they could. In terms of my own personal preferences and practice, I am a little bit different than some in that I have a standard cutoff for what I will do in terms of reconstruction. That's a BMI of 35, and there are a number of papers that really support the idea that once you get to a BMI of 35 or above, the complications in any type of plastic surgery, including breast reconstruction, go way up. So some patients, when you tell them that, will say, that's fine, I don't care, I'm willing to risk that, I just want some reconstruction. But it's sort of your job as their surgeon not to hurt them, number one, and then number two, you have an obligation to society and to your hospital to not do things that are going to have a high rate of failure and a high rate of complications and cost, all the while trying to balance that with satisfying your patients and satisfying your breast surgeons. I find that is, in fact, the biggest challenge I have is with the breast surgeons at times really have a hard time grasping this idea about how BMI affects outcomes of reconstruction. And that is that many times that it's felt that all patients, no matter what, should have reconstruction, and that if we withhold that for whatever reason, that it's somehow mean or dishonest or is somehow slighting the patient a right that they have for reconstruction. And I understand that perspective, and I'm very sensitive to that. But at the same time, as I mentioned before, I think we have an obligation to do what we think is in the patient's best interest. And when patients come in with obesity that's significant, that is greater than 30 or even 35, 40, I think the most important thing in their life, besides the immediate cancer care, is to lose weight. It's been shown in multiple studies that their long-term breast cancer outcomes are directly related to weight. We know that, many studies have shown that, and that other areas of health are directly related to weight. So to simply ignore that and to say, well, let's do your reconstruction because you'll feel better and you'll lose weight later after you do the reconstruction, I think is not the correct way to go. I think that patients can take this opportunity right after they've had their mastectomy to focus on getting their health as best as possible. There is no better time than right after this diagnosis and treatment to focus on this weight management. And so that's my usual goal, is to try to get patients down. And I try to really be supportive and to partner with them during the weight loss time by seeing them every 3 months or so, checking on their weight, and then having this goal, this very defined goal of 35. So that when they reach that, they know that they're going to be a candidate at that point. Now, once a patient becomes a candidate for reconstruction, and again, in my practice, that's a BMI of 35, then we got to decide what type of reconstruction to do. I totally agree with this paper and others in that the results of implant-based reconstruction in the high BMI patients is not very satisfying, both in terms of acute complications, infections, skin flap necrosis, but also in terms of long-term outcomes and satisfactions. And part of that is because in order to get implant reconstruction to work in these patients, you need to use a very large implant. Oftentimes, it's not possible to do this with a 350 or a 400 cc implant. We're talking about often 800 or even overfilled implants that cause so much weight and so much pulling down on the chest skin that they're uncomfortable. They often result in malposition due to stretching of the skin. And it's very hard to get an acceptable long-term result. Also, many of these patients have extra weight in their lower abdomen. And many of them, if they've gone through the weight loss steps, have weight and extra skin that is easily available to be used for autologous reconstruction. So I think there are many reasons why autologous is preferred in this patient population, not the least of which is less complications, but there's other aspects as well in terms of satisfaction and overall body improvement that is associated with autologous abdominal base reconstruction.
Definitely. Thank you, Dr. Hollenbeck. I think some of those are really excellent thoughts. I wanted to go ahead and Kyle and see what the preferences were at Southwestern and if there is a BMI cutoff for reconstructive surgery in general and then microvascular surgery for breast reconstruction. I know the group there is abdominally based, but also a lot of other flaps as well. And what is the preference in patients who are obese? As certainly, I'm sure that's a problem in Dallas as it is here.
In general, we do mostly autologous. Our cutoff is roughly BMI of 40. With that being said, we have looked at abdominal wound complication rates, and wound complication rates as a whole. And in those higher BMI patients, in addition to educating them about their higher rate, we prophylactically do things like umbocide or umbectomy, where we remove the umbilicus, so there's no additional incision on the abdominal flap. They don't have any umbilical reconstruction until 3 or 6 months out. Most of them never end up wanting it. That significantly helped our wound breakdown rates and our complication rates as a whole. We've tried using implants, and when I first started at UT and at Parkland, they tried to use the biggest implants they made, 800 cc's on large BMI patients, and we were just having lots of complications. And so they've transitioned over to doing almost all abdominal-based reconstruction on the higher BMI patients, and based on those results and those data. The other thing they do is they're very efficient in the timing of it, so we're trying to get the patients out of the OR as soon as possible. In terms of that, seems to have helped us as well. At Parkland, we have a little bit stricter criteria, and we've not only with high BMI patients where we won't do autologous reconstruction until they reach certain goals, but also to the point that we won't do any breast reconstruction, even expanders, at the time of their mastectomy, if they have certain, high BMI, other comorbidities, diabetes, smoking, things like that they're not willing to give up. It's been met with some difficulty with some of the breast surgeons who aren't understanding why we don't want to do reconstruction in, a high BMI diabetic smoker. It's been a long process of educating them. I think we finally have a great understanding and really have patients and surgeons educated on the process, but mostly it's just making sure that we're managing their expectations and trying to minimize any other risks to wound breakdowns.
Thanks, Kyle. I think those are excellent points. I do think it's really interesting in breast reconstruction specifically, where it seems that if you look at a lot of the papers published and just anecdotally from if you talk to people in clinical practice, where it seems some of the cutoffs in other reconstructive surgeries that we would use and say, okay, we can't operate or we can't offer you an operation safely, that some of those go by the wayside in breast reconstruction. For example, if you look at a majority of the papers, BMI, smoking are two clear examples of factors that can be modified, and yet almost every series on breast reconstruction, the smoking rate is around 10 to 20%, often as high as that. And the BMI is, around 25 to 30% of patients in those series are obese, and sometimes even a lot higher. So clearly, we're operating on these patients. And I think the other thing with prosthetic reconstruction in general is the amount of patients who are getting radiated and still getting implants. In this series was 50%, and then you look at some other series, and it's very similar. And that's also obviously a known risk factor. So I think what Dr. Hollenbeck said is really the goal is better education, having kind of a shared decision-making approach and really educating our patients, but also the referring providers on some of the risks. And certainly a lot of these procedures can be done in a delayed fashion. And I think that's why we see that some of the immediate risks or some of the risks of immediate reconstruction are higher, is because I think some of these factors become more important. And if the risk factor is modifiable, I certainly agree that I think waiting to do a delayed reconstruction, educating the patient on why that's important is a good alternative. So I wanted to get your thoughts too, Lily, on the article in general, and then what you think when you go into practice on BMIs and ways to modify that and get patients to goal.
Yeah, thank you. I think we've been having a great discussion so far. I think a lot of the points that have been brought up were sort of my initial thoughts when reading the article. I think the article sort of reaffirms a lot of things that are just sort of classic in our breast reconstruction teaching, that patients who have higher BMIs are often better suited for autologous reconstruction than implant-based reconstruction. And then also things like, implant-based reconstruction doesn't tolerate mastectomy skin flap necrosis as well and has much higher rates of infection in the setting of that, when you have a prosthesis or prosthetic underneath that threatened skin as opposed to a healthy flap. I think the paper I found to be a little confusing the way they were describing sort of the timing of the reconstruction of a lot of their patients, in the differences between sort of immediate implant versus immediate delayed. And then they sort of described a more common, immediate delayed reconstructive process where they're using tissue expanders. And it was a little unsure from their description if they were placing tissue expanders in their flap patients at the time of mastectomy or if they were truly having immediate flaps. And then I think some of the things that we've talked about, that they didn't necessarily answer, which is how are we mitigating risk in these patients? I've heard a lot of teaching similar to Kyle mentioning what they've done at UT Southwest for removing the umbilicus in some of these patients. And then also just what, is 35 the safe limit? Is 40 the safe limit? You have some surgeons kind of proclaiming, I don't have a BMI cutoff. I think everyone should be entitled to have breast reconstruction, but what is that sort of safe threshold to where we cross over into really starting to do harm for the patient? So it's something that I've thought about a lot. I don't know if I have an answer for your question about what my sort of BMI goal would be or cutoff would be in practice, but I do think the paper kind of confirms some things that we already know and leaves some unanswered questions still unanswered.
Definitely. Yeah, I think for us, at least at our institution, and I think what my cutoff would be is I agree with Kyle. I think 40 is traditionally what we do here, and with exceptions, obviously. But if it's over 40, and that's for immediate reconstruction, if it's over 40, then we do advocate for weight loss and a delayed reconstruction. And then definitely for patients with higher BMIs, especially once you get over 28, 30 into that area, then we do, as long as they're a candidate, we do advocate for microvascular reconstruction. But we do it in a shared decision-making approach. Obviously, patient preferences matter, but a majority of the patients, I think, would opt for autologous reconstruction, and we show them pictures and examples, in people who have similar BMIs to them with permission, and then, they kind of make the best decision. I think the implant sizes are certainly a challenge. We were on trial for one of the device companies using the larger devices that they have available in Europe or used to have available. But certainly, with everything going on around implants currently, that's becoming less and less favorable as well. With that said, Dr. Hollenbeck, I wanted to get any last thoughts you had on this article in general, and then on microvascular breast reconstruction in the obese population, and any tips and tricks you've picked up for doing microvascular breast reconstruction in patients with higher BMIs from 25 to 35, understanding that your stated cutoff is 35.
Our discussion does bring out the notion that there is no accepted practice, actually, and what is occurring at one institution or in one person's practice may differ substantially from another, and I think that's part of the difficulty and the problems with this particular area, that is obesity and breast reconstruction. The other complicating factor is if you don't offer the patient reconstruction, the breast surgeons often will find somebody that will. And part of that is the concept we talked about earlier with one of the other papers, that as a plastic surgeon, we make other people's lives easier sometimes. And when you take a patient on and do an immediate reconstruction, I can assure you it makes the breast surgeon's life a lot easier because they're no longer managing the post-op care of that patient. They will review the pathology and the plastic surgeon will manage the post-op care. And that's difficult. It takes a lot of time, takes a lot of effort, emotional energy, all of that. And so if you tell your breast surgeon that you're not going to do the reconstruction, there is the potential loss for patients, and that can translate into loss of revenue and other things. So it's a very complex issue, but I think at the end of the day, you can build your reputation by doing things that are based on data, based on papers like this, and also doing things that are truly in the patient's best interest. And when you have patients that you can get them to lose weight and get them down to a lower BMI and then do the surgery, those are some of the happiest patients I have of all. Their life has been totally transformed. They've gotten control of their health overall in the setting of a breast cancer diagnosis. And we've been able to use some of that extra tissue and skin to rebuild their breast and try to help rebuild their lives. And they're usually very, very pleased with their new outlook on life and also their new body, if you will. So that's my sort of approach to this. It is one of the most difficult and complicated topics, and it's something you need to be very sensitive about when you're discussing this with a patient. You want to be their advocate, you want to be on their side, and you want to be their partner in this process of losing weight. In terms of the choice between reconstruction techniques, that's another heavily debated topic. There is no current mandate by the societies or by any organization that you have to do implants for this or you have to do flaps for that. That would perhaps be reasonable, but would be difficult to get something like that through with large approval, considering that many surgeons out there don't offer all the different forms of reconstruction. And you could even drill down and say, well, if you don't do lumbar flaps, then you shouldn't do breast reconstruction. And so where do you stop in terms of wanting people to have a wide breadth of options for patients? So you end up with a lot of surgeons that only offer implant reconstruction. So for them, that's going to be what they deliver for all patients, and BMI may not even weigh into the decision making. So it's an extremely complex topic. I'm delighted to see this paper contribute to the discussion. Happy to be part of this discussion as well with you all today. I've really enjoyed being here.
Thank you, Dr. Hollenbeck. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Also, remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Hollenbeck, for joining us today.
Thanks, Raj, Lily, and Kyle, and good luck to all of you.
Thanks for listening to the award-winning PRS Journal Club podcast. Please click, subscribe, and leave a ratings or review if you're enjoying what we do every day.